Thank you, everybody, for booking onto this EDS UK webinar with Dr. Chloe Angwin on skin fragility and wound management. And Dr. Angwin, thank you so much for taking the time to share your expertise with us today. I will hand over for you.
Hello, right. Really nice to meet you, everyone. My name's Dr. Chloe Angwin. I'm one of the doctors at the National EDS Service. So, just a little bit about me and who I am. So, I'm a clinical research fellow at the National EDS Service. I particularly work with rare diseases and um, and rare types of EDS with a specific interest in skin because I'm a dermatology registrar. So 2 years off consultancy. I'm doing my PhD at the moment, and then I'll go back to my dermatology training, um, and then I'll hopefully come back to the National EDS Service, and that'll be that. So I also just wanted to quickly say Happy International Day of the Zebra if anyone's celebrating, and let's get started. So there we go. So, the plan today, as Nikki said, the webinar is 90 minutes. So what we'll do is a 60-minute talk with quite a few breaks just to keep it nice and relaxed. It's Saturday morning. And then we'll have 30 minutes for questions at the end. So please, whenever you have a question comes up, just pop it in the chat and it'll be great. We'll have a really good discussion at the end. So what I'm going to do first is talk a little bit about the background and understanding about Ehlers-Danlos syndromes, the skin, wound healing. So it's quite science heavy towards this bit of the webinar. Don't worry, there's not going to be a test. It's just to help you get an understanding of why some of the things happen that happen and why we recommend the things that we recommend. So, as I'm sure you know, 14 different types of EDS. There were the original 13 published in the 2017 big paper. And then following that, classical like EDS type 2 was also discovered a little bit later on. So that's added on at the bottom. They're all called Ehlers-Danlos syndrome, as I'm sure you know, because each of these separate conditions shares features of joint hypermobility, skin hyperextensibility, and tissue fragility. Most of them have a known genetic cause, and where the genetic cause is known, it tends to be genes that affect the components of the connective tissue. So, your connective tissue are the tissues in your body that don't belong to a specific organ, but they create strength and they give those organs, like your liver or your spleen or your kidneys, they hold them in place and give them support. So the connective tissue is different all around the body, but it makes up things like your joints, your muscles, your skin, your bones. So it's really important, as I'm sure you can imagine, and it's very, very variable. And there's loads of different components, thousands of different components. The one that we look at in EDS tends to be collagen because lots of the EDS conditions have genes related to collagen or collagen processing or molecules that are adjacent to collagen. That's not true for all the types of EDS. Some of them we don't understand how they create the features that they do, but we're working on that. There's also one other type, hypermobile EDS, and we don't know the genetic cause for that. It's still being worked out. There's some huge studies going on. I'm sure lots of you have already seen things like the hedge study. And so far, we still haven't managed to come to a satisfactory conclusion for why people with mobile EDS have the features that they have. So we still don't understand, but we're working on it. So let's talk about the skin a little bit. So the skin, as you can imagine, it does lots of different functions, sensation, temperature control, uh, sweating, and there are lots of different parts of the skin that we can talk about, but the part that I'm interested in is the dermis. So this is where your connective tissue sits. This is where your collagen sits. And this is what we're talking about today. So the epidermis is the upper layer. Let me just go back. So the epidermis, that's the upper layer. That's the bit of skin that you can touch. It's the bit of skin where you can see your hairs coming out. And the hypodermis is the bit where your fatty layer sits. Everyone's got a little bit of fat. We need it to keep us warm, to keep us shielded. But we're talking about the dermis today, which is where all the collagen is. So, what makes up the dermis? It's made of collagen mostly, so type 1 collagen, and that is laid down in these huge ropey bundles, and they really do look like ropes, and they're supported, which you can't see in this picture, by lots of other proteins and other molecules. So things like elastin, hyaluronic acid, which I'm sure you've heard of because it's in all the face creams at the moment. There's lots of other things, teneskins, proteoglycans, glycoproteins, loads of different things, but they all work together to keep these big ropey bundles in place and lying nice and straight to and what it does is it gives us what's called tensile strength in our connective tissues. So it gives us that ability to withstand force. So if you get hit on your skin for whatever reason, your skin doesn't break. But you can imagine if you have a defect in collagen, or if your collagen is a bit more fragile than other people's, when you get an injury to the skin, it's more likely to be more fragile. And if it's not the collagen in you that's affected, but it's one of the other proteins and molecules in the skin, that will also make your skin more fragile because those ropes aren't supported in the same way that they are for people that aren't affected with EDS. So let's move on quickly to talk about skin healing. So there's 4 different steps to skin healing. It's called hemostasis, inflammation, proliferation, and remodeling stages. So hemostasis, that's clotting. So you get a clot, you get a cut, and as you know, you'll bleed lots, and then the bleeding gradually stops and you form a little scab. So that's the first thing. It happens in maybe a few minutes, half an hour, that everything's clotted off and that your body has formed a kind of plug over the area of injury. Next, what happens is inflammation. So I'm sure you all recognize this. When you have a cut, it starts to get redder and hotter and can be a bit warm. It's not necessarily infected, it's just inflamed. And that's because your body is sending in your defense system, which is your immune system, rushing into the cut to try and clear out any foreign bodies that might have got in there. So little bits of dirt, bacteria, little fungi from the atmosphere that have landed in the cut while it was open. Your body clears it all out at the inflammation stage. Once your body is sure that the inflammation has worked and there's no more nasties and no more infective objects in there, it moves on to the proliferation phase. So what that means is lots of different cells start to flood the area, and they're the cells that produce the connective tissue. So they start to produce loads and loads of protein, different molecules, the molecules of the connective tissue, and fill that area with all of these proteins. So it's really, really rich and full of different parts of the connective tissue, but not organized. And that's called granulation tissue. And that stays under your scab until you get to the remodeling phase. So proliferation happens over days to weeks. So hemostasis and inflammation, I'm sure you can remember when you've had a cut, they tend to be days, hours to days. Then the proliferation is days to weeks. You still got your scab on there. It's not coming off. The wound's still working away. And then in the months to years, you start to have remodeling. So what that means is that your body gradually settles all your collagens into the right orientation. So in our skin, collagen is laid down against lines of force. So it looks really organized because it's there ready to pull against any kind of traction and tension. So the remodeling phase is when that happens. Before the wound is fully remodeled, scars can be quite fragile and quite delicate, can break open quite easily. Once they've remodeled, as they go over the years, they tend to get tougher and tougher. However, that is not necessarily, this is a model of classic healing in someone who's not affected by EDS. However, if you have a type of EDS where you have abnormal scarring, like atrophic scarring, the remodeling phase is where you start to see problems come in. And that's why the wound is so much thinner, because during remodeling, the collagen isn't laying down in the same way as the skin next door to it. So the scar is really, really thin and fine rather than having that same strength as the rest of the skin. So let's quickly talk about some of the features that I look for rare EDS and hypermobile EDS when I see patients in clinic. So it's always nice to have pictures. I love to have a good picture. I'd be really grateful if people don't take any photos of these patients, because they've kindly given their consent for this to be published in a scientific journal. So it's already out in the world, but I'd prefer it for it not to be on people's personal devices, just as a picture, if that makes sense. Obviously, fine for it to be recorded as part of the webinar. So skin hyperextensibility, there are very specific measures for skin hyperextensibility. It needs to be over 3 centimeters on the elbow or the neck, and then over 1.5 centimeters on the back of the hand. And these people obviously have really, really stretchy skin. These are people with classical and classical-like EDS. This is a graphic image, so if you don't want to see an image of a wound, please don't look, and I'll let you know when you can look back again. But it's helpful because lots of people with EDS do have these wounds, and it's nice to know that you're not alone and that this happens to lots of people with EDS. So please look away now if you don't want to see a wound. So this is the laceration after friction in someone with dermatosparaxis EDS. So this is a condition where the skin is very, very fragile. But lots of you with other types of EDS that have skin fragility will recognize this kind of wound, where it goes right down through all of the skin layers and forms a really big laceration. And then it needs to be closed with extra support. So this is a skin split in an individual with classical EDS, where it's needed to be closed with extra support from tape because the skin is so fragile. All right, so if you did look away, you're fine to look back now. No more pictures of wounds. So atrophic scarring. This is a specific type of scarring that we look for, but we find that it's, even though it's got one name, it's different for different people with different distinct types of EDS. So the typical description of atrophic scarring is one that you'll see in classical EDS. And you can see this elbow in the middle is a classical EDS elbow. And the scarring is very, very thin and fine. And if you run your finger over it, it feels almost like tissue paper or like very thin fabric, like a chiffon or something, if you know your fabrics. It's very fine, and it doesn't have that body of strength that the rest of the skin surrounding it does. There was a really nice comparison picture in the hypermobile EDS paper in the 2017 big publication that the Malfay team did and the world experts did. And this is by Barry Tinkle, who's an expert in the US, showing the difference between atrophic scarring in hypermobile EDS and classical EDS. And you can see that in hypermobile EDS, it's called mild atrophic scarring, which is just the name that's been given to it. But you can see that even though the scarring is abnormal and the scars are stretched, they're very thin, they don't have that real kind of It used to be called the scarring in classical EDS, the typical atrophic scarring used to be called cigarette paper scarring. If you've ever seen a cigarette paper, it's incredibly thin and tissue-like, and that's what the scarring is like in classical EDS. However, as part of my PhD, I'll give you some early insights before I published it. But what we're finding is that scarring is becoming much more of a spectrum, and we can see all different types of scars in all different types of people with EDS. So, but that's developing research. But typically, this is what you would see. And you can see on the left here a lady with dermatosparaxis EDS who has very atrophic scarring on her knees and very thin scars that have started to really sag and droop, but not again. Dermatosparaxis is not the same kind of scarring as in classical EDS and not the same scarring as in hypermobile EDS. So everyone's very distinct in their specific conditions, even though they're all called EDS. So bruising, easy bruising is something that common to lots of different EDS types. So you can have, this is a recurrent hematoma, and a hematoma is a bruise where rather than the blood just being caught under the skin, it started to swell and pool in a big bruise, which is then takes a really long time for your body to process and sometimes needs medical intervention, which I'll talk about later. This is someone in the middle with vascular EDS who has really significant bruising after just minor injuries. And again, there's a big variability in the field of vascular EDS. So some people will have really, really severe bruising. Some people will have less severe bruising. And on the right here is someone with periodontal EDS, and they have what's called hemosiderin staining. So that's permanent bruising on both shins, which is takes a really long time for your body to process. And when I say really long time, I mean years and years, if it will ever go. In people with periodontal EDS, they also have something called pretibial plaques, which is where the structure of the skin starts to change. And that won't go, that continues to gradually progress over somebody's lifetime. So other changes that we look for on the skin, things like molluscoid pseudotumors, these are kind of big collections of collagen which isn't organized at all. And we usually see that in classical EDS, and we typically see it on pressure points, so knees and elbows. Very thin, translucent skin is something that we look for in vascular EDS. And that's not the same as someone having super pale skin. So I can see my veins through my skin, but you can see in this picture, hopefully, how close the veins are running to the surface of the skin, and that there's really almost no covering on them at all. So the skin is translucent because of its thinness rather than because there's less pigment. And then the last thing we look for, which I'm sure lots of people will have noticed, is something called pesogenic papules. So these are also seen in the general population, but pesogenic papules are where, so under our heel, we have a fat pad, and that stops us from walking on bone on the ground. We need that fat pad, and it's protected by a kind of basket of connective tissue. So if your connective tissue is looser for whatever reason, the fat will poke out of the basket whenever pressure is put down. So when you stand on your heels, those little balls are little parts of the heel pad which are coming out through the basket, and they pop back in when you take the weight off. There's something to look for. They're not specific to any one type of EDS. For the majority of people, they don't cause any problems. Some people do experience problems when they're very large, and they can rub on shoes and socks and things, and you can get a lot of friction from them. So they're not 100% totally harmless if you've got very large ones, but for the majority of people who have them, For the majority of people that have them, they're not a concern. So, shall we have a quick break? That was all the science and education bits. And then we're going to talk about what we recommend and what we've recommended in our recent paper. But it might be nice just to have 5 minutes, just have a little sit, get a cup of tea, go to the loo, and then we'll come back again.
Thank you, Chloe. And thank you very much for the warning on the um, pictures
Yes,
as well.
yes, I know. It's quite graphic, and not everyone's ready to see that on a Saturday morning. But it's important because people with different EDS types do have those wounds, and that's what we're talking about. But you know, not everyone wants to see that. It's
Just
um
replying in there. Yes, the recording will be available afterwards for people who have been here today. Lovely picture.
oh, so relaxing, isn't it? Oh, wouldn't it be nice to be a red panda in a tree?
In the sun.
Mm, yes, please. The sun. Although it's quite sunny here today. I thought it was going to be rainy, but
Lucky you. Where are you? South of
yeah.
England?
Yeah, I'm towards Southampton.
Okay.
Where are you, Nikki?
I'm in Milton Keynes in Buckinghamshire.
Oh, very nice. What's it like up there? Is it rainy and a bit
It's not
miserable?
raining, it's just dull. You know that just it's just dull and grey and dull.
Yeah. Well, I hope the sun gets up to you.
Me
Maybe it's on its
too,
way. You never know.
hopefully.
Clouds might be breaking.
Right. Do you want to get going or shall I?
Yeah, if everyone's happy, hopefully.
Yeah.
Anyway, we can always, if someone missed something, I'm happy to go back. It's not a problem.
That's
Lovely.
okay. They can have the recording anyway, so that's fine.
Perfect. Right, let's move on then. So, recommendations. So, most of these recommendations and what I'm talking about today are coming from this paper, which was by the International Consortium on Ehlers-Danlos Syndromes and Hypermobility Spectrum Disorders, because I'm part of the skin working group. So I work with Dr. Burrows, who's the chair of the group, and then we've got dermatologists from around the world who have an expertise in EDS who join in with us. Um, so so we wanted to try to collect all of the information on skin fragility and wound management in Ehlers-Danlos syndrome. So I went through all the literature that's been published in the world so far and tried to collate it into a big paper. And what we found was there is not much data on how to manage wounds in the best way in Ehlers-Danlos syndromes. There are lots of small case studies of individuals who have had one thing or another done. There are some studies done by surgeons where they've got slightly bigger groups, but understandably, because it's a rare condition and because diagnosis has only really picked up over the last 20 years or so, the the literature available was not very significant. So we also added an expert opinion piece. So all of these individuals, so dermatologists and plastic surgeon, Mr. Donald McKay, gave their expert opinions on how we should be recommending that wounds are managed. So it's also important to say that uh, this is just expert opinion. So there's no official guidelines. That's something that we would need to work on once we've got more data. And so we need to do more work, and I'll talk a bit more about that at the end. But as long as you know that this is the best that we've got, this is the best that we've come up with so far, and that we're working on more things for the future. The other thing to say is that this is I'm just going to be talking about management of skin fragility and wound management. So I'm not talking about other things that people with different types of EDS can experience. So things like MCAS really needs its own talk by an expert on mast cells. So I'm not um, I'm not talking about that today. Hopefully, if that's something you're interested in, we can organise that with someone like Siranjit Sevanarapne, who is also an immunologist and should be able to give some good advice. So the last little thing to say is that this is general advice, but each person who's affected with a different type of EDS will have a different experience. It's important to know how your body reacts to things rather than just having listened to this talk and saying, oh, I've got to do all the protective things, because it's a balance between living your life and protecting your skin. And sometimes you can't have the balance swings one way or another. So I don't want people to get too stressed and worried and think that you have to not ever do anything ever again because of these recommendations. It's very blanket, and that's because I'm not seeing you in clinic. This is just a webinar. If you see someone in clinic, obviously they'll give you more personalized advice. But what I would say as a takeaway from this is that you will know your body's best, how your bodies react to different things, what things might cause injuries, what things might not. So, so please listen to that and take all of this with a pinch of salt and take it in with a view towards your experience of your own body. So, with that in mind, let's talk about prevention. So, our main advice is to ideally prevent and avoid injury where possible. And that's not always possible. Accidents happen, things happen that you can't change. So, but you can avoid things with a high likelihood of injury. So, for example, contact sports, sports where maybe they won't cause an injury to do the sport, but if something goes wrong, for example, I'm thinking things like mountain biking, riding on a bike won't necessarily cause any skin injury, but coming off your bike, you could risk a lot of injury. So it's balancing out and thinking about how an activity might pose a risk if you're someone who experiences skin fragility, and trying to reduce those activities where you can. And then skin conditioning. So this is really kind of very basic advice. So sun cream. The reason that we recommend sun cream is because UV rays break down all of those components that I was saying in your connective tissue in your skin. So they gradually will break down the tenefkins and the elastin, and those are all things that support collagen. So as the collagen supports gradually break down, your skin gradually becomes more fragile. And that's why older people have more fragile skin than younger people, just because of slower turnover of collagens and because of UV exposure. So sun cream can be really helpful in preventing some of that fragility in later life. We also really recommend moisturizing, and that's because lots of people find that they have skin fragility on their hands and they'll have lots of tiny little cuts and fissures, particularly when your skin is dry. So, moisturizing, especially in this weather when it's really, really cold, because the cold pulls moisture out of your skin, which is why people's hands get really dry. So, making sure that you're up to date on your moisturizing is really good. In terms of using moisturizers, the best moisturizer is one that you get along with and that you like to use. I really like oat colloid moisturizers, so that's things like Aveeno or Zerovene, because they feel really light, but it depends on your skin, it depends what you like. For really heavy moisturization, things like ointments are really helpful. And sometimes you can put ointments on at night, so they're not as irritating and sticky, and then use lighter things during the day. And then the last one is nutrition. So eating a really balanced diet helps to provide your skin with all of the nutrients it needs to continue to produce that connective tissue as well as it can. That's easy to say, sitting on the other side of a computer. And obviously, lots of people with EDS have problems with diet and digestion. So nutrition isn't as easy as it sounds with me sitting here. But for people that don't have as many digestive problems, trying to get that really balanced diet is really helpful. And I'll talk a bit about specific supplements later. So next prevention is protective clothes. So these are for people who have lots of fragility and can have injuries from very, very minor activities. So this isn't people talking about doing contact sport. This is people who could get injured from walking into a door or walking into a desk and might have significant bruising or cuts. So protective clothes are number one. And then prevention of which I will talk. So let's talk about protective clothes now. So these are all suggestions. It depends what you get along with, will that which you should use to guide you into how you use protective clothing. So tuber grip, that's a really light bandage, which you can use in a double layer, and it can just go over high risk areas. It doesn't offer lots of protection, but it might offer just enough. Then neoprene, I really like to recommend neoprene to our children with classical EDS. And the reason for that is that it's lightweight, it's fairly comfortable to wear, and it goes under clothes really easily. So it doesn't look like you're wearing lots of big protection. And you can get lots of different wraps. So they tend to be Velcro so that you can wrap them wherever you want without having to buy something specific for specific locations. There's also sportswear that's specifically designed to prevent injury. So these are leggings that you could wear under trousers, which have pads sewn in. Some parents I've met sew pads into their children's trousers to prevent injury without so that they can wear whatever they want, but they have that extra protection already sewn in. Some people use foam helmets for their children because, especially children with classical EDS, get lots of injuries over the forehead when they're toddlers because they're falling lots when they're trying to walk. And that's where the skin gets caught, is on the forehead. So foam helmets can be really helpful. And then hard pads, like shin pads and elbow pads, knee pads, these all exist as well. They're a bit more difficult to wear and a bit more uncomfortable, but they obviously offer the best in cut prevention. Some people have said to me that they find that the hard shin pads, though, do cause bruising by themselves because they don't move with the skin. So when you get a hit, the shin pad will carry the impact through and cause a bruise, but it might protect from from any cutting injuries. So it really depends on what your skin is like, what kind of injuries, and where and when you're having your injuries will help you decide what kind of protection you want to wear. It also depends on what kind of clothes you want to wear, what kind of job you do, what kind of activities you do, how happy are you for people to be able to see that you're wearing protective clothes. Some children and teenagers, for example, are really reluctant for anyone to know that they need to wear extra protection, which is why the neoprene and the tuber grip is great. Last point on this is duoderm or hydrocolloid dressings. So these are non-adhesive dressings which have a really squishy texture, and they're really helpful for any pressure areas, any areas that get rubbed, any areas of friction. So particularly if you're someone who has pedogenic papules that keep rubbing, if you're someone that's really prone to blisters, hydrocolloid dressings are great. They come in all different thicknesses. You can get really, really bouncy ones. You can get really thin, fine ones. And they just act as an extra layer on the skin, particularly on vulnerable areas, and can give you that extra bit of protection. So I think hydrocolloid is really, really helpful. The other thing to say about hydrocolloid is you can buy it in big, huge rolls and then just cut it to the shape that you need. You don't have to buy a square like in this picture. You just get a big roll and then you can put it wherever you want, whenever you want. It's also the same thing that people use for spots. There's the special little spot dots that people wear. That's just hydrocolloid. And instead of buying very expensive dots, you could buy a roll and use them for whatever you want. That's just an aside. So let's talk about prevention of further injury. So sometimes people find that really adhesive dressings, really sticky dressings, will pull the skin away or lengthen the cut. So you just try to heal this cut and then you take the dressing off and the cut reopens and also gets longer because the dressing has pulled it away. Some people find it takes off the surface of the skin. So there are a few ways to address this. So first of all is if you know that there's a dressing that does this, trying to avoid it and using non-adhesive ones where you can. And there are a big range of low adhesive or non-adhesive dressings. Sometimes you can use the hydrocolloid. If you can't use the hydrocolloid, there are other dressings you can use. There's a huge amount, so please have a look around online and see if there's something that you get along with. Sometimes you can use non-adhesive dressings, which you put on and then you put a bandage around it. So it's got no adhesive whatsoever and it's all held in place with the bandage. That depends on how good you are at keeping the bandage in place. So for small children who are super, super active, that might not be a good solution. If you can't avoid adhesive dressings, what you can do is when you take off the dressing, rather than taking it dry, there are sprays which break down the glue of dressings. So you can get those which stop the glue from sticking to your skin, or you can just soak it in water. Depending on the cut, it depends on the injury, but sometimes you can just use water just to soak it away and it will just pull away. So let's talk about bruising. There are two big points to make for bruising. If you're someone that takes ibuprofen, it's if you can, it's best to avoid it 24 hours after a big bruising injury. Obviously, if you're someone that gets lots and lots of tiny bruising and you have loads of joint pain, you need to take the ibuprofen and you can't hold it off for every single tiny bruise that you get. But if you've got a big injury, like you've just fallen and you know that your ankle's going to end up really, really bruised, it might be wise to try to avoid the ibuprofen because ibuprofen stops that initial clot from forming. If you remember back to the wound healing, ibuprofen stops your platelets from working so well, and it means that the bruising can be exacerbated and just continue developing because the clotting isn't happening. So the bruising just continues under the skin. The other thing to say is vitamin C. So the evidence for vitamin C is not amazing. There have been some studies that say that in the lab, vitamin C seems to encourage cells to grow collagen. So the theory is if you boost as much collagen production as you can, that should hopefully reduce a small amount of the fragility of the connective tissues, enough to reduce the bruising. There's been no big studies on humans, and there's been no big studies on humans with EDS. So we can't say how well vitamin C works, but it's relatively harmless. Vitamin C supplements are good for you. You don't have to take loads and loads of vitamin C, just an over-the-counter supplement, and it might make a difference. So it's maybe worth giving it a try. So this is our table from our paper, which also talks about hematomas. So hematomas are where the blood starts to fall under the skin rather than just lying on top of the first layer. So a bruise can be a little bit swollen and painful, but a hematoma is where it really starts to puff up. That is where you might need some more medical intervention. So, depending on what kind of hematoma you have, there are lots of different things you can do. And if you read the table, you can see we're recommending all these different things. You don't necessarily need to know about all the different options for hematoma management, because the first things you should be doing when there's something like this happens is an ice pack and compression. And that's for at least 10 minutes, ideally 20 minutes, holding the ice pack on as much as you can, to try to help your body cause a clot and try to stop the hematoma from progressing. For most hematomas, the best course of action is, if it's not progressing and not growing anymore, to leave it alone and let your body deal with it. Very rarely hematomas can get infected. So if you've done that and it stopped growing and you think it will be fine, but then the next day it's getting really hot and it feels red, it feels even more painful, that's a sign that potentially it's infected and you should seek medical advice. For some people who have really frequent large hematomas, we recommend that they have tranexamic acid, which stops the hematoma from progressing. So, if anyone here has periods, you might recognize tranexamic acid as something we give people who have really heavy periods, just because it helps to reduce the bleeding. Um, so that's hematomas. So it's important to just know that ice pack and compression are the most helpful things that you can do as an individual at home. But if things are progressing, if things are not right, if it's really progressing and getting really big, that you might need to seek medical advice for a hematoma, because there are things that can be done. It's not something that just needs to be left. All right, so let's have another couple of minutes just as a breather, and then we'll start again. And then I've only got a few more slides left because I know we're at 46 minutes already. So we'll just have a breath and then we'll come back. All right.
Thank you, Chloe. Oh, I think I like this picture better.
I know. Oh, it makes me sleepy.
It's so cute. You just want to, ooh,
Yeah, I know.
ooh.
Absolutely.
People with cats and dogs know what I mean by, oh,
Oh, I was thinking
beautiful.
my cat might come in, but I think he's having a nap outside. If he comes in, I'll let you know. I'll show you a
Oh,
picture.
yes. No, nobody minds an animal appearing on screen at all, ever.
No, it's the best
Lovely.
part, I think. Better than all the rest of the webinar for sure.
Well, it's a better picture than ripped skin and everything
Yes,
else. Yeah.
exactly. Yes, definitely.
There's some really good stuff in the chat, actually. I mean, I've got questions, yes, to come to you. But just for everyone watching, I don't know whether you're looking through the chat. Um, not there's also just some really good stuff being shared about things like people using olive oil to release micropore, and if it gets
Mm,
too stuck on, and yeah, just kind of going through it. It's definitely worth a little look through if you're sitting here just waiting now, because yeah, some really good tips from people who are living it. I think
yeah,
that's really important, and some people talking about that vitamin C reducing bruise frequency and helping, and um Jessica, I love that. That's something that I say. We don't bump into things. Things bump into us. That's what I tell my husband when I hit the car. Um,
Amazing.
yeah, yeah. And it's funny, isn't it? Being called accident prone, as Rosie's just put, and all those kind of terms that were on people as we grew up, and actually, it's just our proprioception, and there's an issue, with
Yeah.
if you're neurodivergent or all these kinds of things, and now we kind of understand that. Um, yeah, it's hard for some people.
Yeah.
It just is, and I get dizzy often, and I think people with POTS and those kinds of things can sometimes be kind of getting or going around their life doing a normal, very normal thing like putting the washing in, and then all of a sudden you've knocked your head on the door, your elbow's gone on the thingy, and you're like, what on earth?
Yeah. Yeah. Yeah, that's so true. Oh,
And
yes, I
I
know.
learned a very interesting fact the other day I was watching a thriller film actually, so I presume it's correct. You'll tell me that, and it's a bit morbid, but after you die, your bruises still appear.
Mm.
That's what they were talking about because when this person died, there was nothing on them. But when they went back 3 days later, they could see the strangulation finger marks. They'd come out, and they were talking. And I thought, gosh, really? I thought maybe they're just
Wow.
making that up.
I don't know. That sounds like something that they've got from somewhere, doesn't it? I mean, I
Yeah,
don't know because we don't do any kind of forensics or anything,
yeah.
but I suppose you could say it kind of makes sense because
And
all
they were
your,
saying
I
that
don't know. I don't know.
that's if somebody dies from misadventure, as they call it, that's why they leave them for a few days before the post-mortem to see if bruising will come out so they can see if they were hit or attacked or something. Anyway, sorry, it's
Wow.
really morbid for a Saturday morning. I do apologise.
Really interesting. I don't know. I've never had. I'll have to look it up. That's
There you
interesting.
go.
I'll look that
See,
up later. Good. That's a job for
every
later.
day's a school day.
Absolutely. Yeah.
Amy, you're not. We are the Walking Dead.
No,
Oh my
but
gosh. Hopefully not. One of the best programs on TV ever. Right, shall we get back
right.
to it?
Yes. Let's carry on. Okay, so skin fragility management. So this is mostly talking about wounds and so lots of this really is so for the next table on the next slide, lots of this is for kind of medical professionals making a decision about how to treat a wound. Um, but let's talk about the main messages. So if you have a skin wound, ideally tension across the wound should be avoided. So what that means is when you bring, so it's called approximation, and what that means is when you've got a cut, you bring the two edges of the cut together like this. What you don't want is for the two edges of the cut to be really pulling against each other. So if you've closed your cut and it's really pulling like that, in someone with a type of EDS, that's really going to impact on how the wound heals. So what needs to be done is that the skin needs to be, the dressings, the way that the sutures are used, need to be used to avoid tension across the two edges of the wound. Ideally, on that note, the area of the wound should be immobilized. So if you've got a big cut and it's across your elbow, ideally the arm should be kept either straight or bent, either one. But as long as the skin's not moving, because when your skin moves, that will put tension across the two edges of the wound and will stop the two collagens that come together will keep breaking them apart. Um, when we take dressings off, this is kind of goes back to our other point about really low adhesive dressings. When we take them off, they should be taken off in the opposite direction of the wound. Because you can imagine if they're really sticky and you've got a wound that's together like this, I hope you can see my hands. Um, if you take it off like this, you can imagine that this side of the wound will just come away with it because the scar isn't particularly strong. So instead of taking it off this way, you need to take it off long ways down across the scar, and that will help to keep the scar in place and not put tension on those that very fine tissue that's just started to form. We've already talked about adhesives and really carefully removing them and using non-adhesive dressings where we can. So let's look at our table from our paper. So this is a big old table. The main thing to know, and so what we did was we split up the wound according to where it is and what size it is. The sizing, we had to make a choice about the sizing so that it covered everyone, children and adults. For people who have skin fragility, people tend, in my experience, people get used to having that skin fragility and they know when their wound needs medical treatment and when they can cope with it at home. So the size guidance is really more for people that are not experienced with the wound fragility rather than people who are, it's their lived experience. So um, what we recommend is when a wound is small and when it's not under tension, so when you see the wound, it's not pulling apart. You can use glue and adhesive tapes like steri strips to keep it closed, and that is enough. And often our patients with classical EDS that we see, that has a really good scarring outcome. So the wound tends to heal quite well and pulls together quite nicely. But those tend to be in areas of non-tension. So it's slightly different over the knees and elbows, where we find that wounds do tend to pull much more because they're just under more tension anyway, even during the remodeling phase. So months and years after the scar, the remodeling phase means that the wound is pulled apart. If wounds are big, they're under tension, they're in a high risk area like around your eye, really they should be seen by someone who has experience in managing people with very fragile skin. So it doesn't necessarily need to be someone that is experienced in Ehlers-Danlos syndrome types, but someone that understands that the skin will be very, very fragile and how to manage that very fragile skin. So for example, in the photo that I showed with the image of the cut, they reinforced the because they were seen by a plastic surgeon, the plastic surgeon realized that the skin was too fragile to suture, and they used adhesive tapes to support the edge of the wound. So they used the micropore tape to support the wound edge and then sutured through that so that the tape gave the extra strength that the skin didn't have. But as a patient, you don't necessarily need to be aware of all the different suture types that are available, but you can show your medical professionals this table and say, this is what is recommended in the literature for how to manage my wounds if I've got a big cut, if that makes sense. Um, so I hope that that's relatively helpful. Mainly the thing is to know your cuts. So if you're someone that has lots and lots of cuts, you manage them really well at home. I know I've met lots of families with classical EDS who have many generations of managing their cuts at home, and they're quite happy. And for the most part, they would not really seek medical advice. And then some people who it's a new diagnosis for them and they want extra input, which is completely understandable, then this table can be really helpful. So it's also all about knowing your body and knowing yourself. And this is just extra help to give you advice for how to think about your skin wounds. So other wounds that you might experience. So wound infections. This is often seen in people with hypermobile EDS who have wounds. Because we don't know the genetic cause for hypermobile EDS, I can't explain to you why that is something that we see, but it is something that's reported quite frequently. If you're someone that's prone to wound infections, it might be worth talking to a GP and asking them to provide you rescue antibiotics if you know that you're going to have something like a procedure where you think it's likely that you will get a wound infection. I can't promise that that's something that will definitely be given, but it's worth having that conversation just to say, I'm worried about this. It's something that I've experienced a lot. Let's then talk about ulcers. So ulcers are a chronic wound. So people often have them on their lower legs. They can be associated with things like diabetes, but not necessarily. People with periodontal EDS are very prone to ulcers, and also people with any kind of venous insufficiency. So if you're someone with varicose veins, if you're someone that gets very swollen legs, you might also be prone to ulcers. The best treatment for ulcers are pressure dressings. Oh, here he is. Pressure dressings and keeping the leg elevated. So what that does is, because one of the reasons that we get ulcers in our lower legs is because all of the toxins and waste metabolites that our blood vessels pull out of our tissues and process tend to pool in our lower legs. So our body finds it quite hard to process things like wounds because those nasty metabolites that are coming out from the processing from killing bacteria, they're not being moved away as fast as they would closer to your heart. So keeping your legs up helps all those pooling toxins draw away and be processed like anything else on your body. So keeping your legs up and keeping the pressure on helps to stop that pooling. So compression stockings, pressure dressing, keeping your leg elevated are really helpful. That being said, um, some people really can't cope with compression stockings because, especially if you've got very tender legs, very painful legs, they are really squeezy and they can be really sore. So it's worth trying, but if you can't cope with it, it's not the end of the world. So don't stress. And the last thing is very large wounds. So some people might need skin grafts, might need special dressings like negative pressure dressings where it literally sucks everything out of the wound. So as long as you know that if you've got a really large wound, there are different options for management, and we discuss them in the paper. So very quickly, because I know that I've already run over. So scarring, when people have atrophic and very thin scars, we may not be able to improve the outcome. And that's because there's a genetic change, which means that people's connective tissues aren't lying down in the same way as other people's. There is also not the research background to say whether something will help or not. So there have been research into silicone gel, but that's looking at very overgrown scars, so keloid scars and hypertrophic scars, not at atrophic scars. But it's worth trying. So if you've got a scar, if you've got a new cut, you've got a scar, silicone gel massage twice a day for at least 3 months might help the scar not to become as widened and as thin as some scars. But the caveat is I've got very little evidence to support me saying that. So it's worth trying. Silicone gel tends to be relatively inert, so it shouldn't cause too many problems. It feels quite nice and silky, but and it may help, but I can't promise that it will because no one's done any studies. Some people ask about laser therapy for scars. There's no evidence that that will help with thin atrophic scars. And surgery, some people do ask about surgery. For some people with classical EDS, surgical scars heal better with less atrophic scarring than a traumatic scar, and we don't understand why that happens. So when someone's got a big area of very, very fragile scars, sometimes uh, revising that surgically is recommended, but that's very unusual. And what we mostly recommend is that that is avoided, because you can't be 100% sure that the surgical scar will heal properly, that it won't get infected, that it won't also have an atrophic scar. And then that means that you've swapped one set of scars for another set of scars. Um, some people have had their molluscoid pseudotumors removed, and that's been documented as very successful, but that is only 2 or 3 patients reported in the literature across the world. So again, the evidence is not brilliant. And then some people have also had surgery for excessive skin folds. So particularly some people who have skin folds over the eyes that's causing them problems with their vision. People have had that removed, and that's been relatively successful, but again, only very small cases. So not lots of people. So the safety numbers, the risk, I can't comment on because the literature just isn't there yet. So other things to talk about, supplements. Lots of people, when they see me in clinic, they ask about collagen. And I do need to say that there's no evidence that having a specific collagen supplement will improve anything, unfortunately. So there's been a big study recently that's combined all of the other studies that have been done, and they found no evidence that collagen supplements themselves improve people's skin quality. It's important to say, oh no, lost my train of thought completely. Stop. Um, oh yes, so on collagen, the most important thing is to eat a balanced diet, getting lots of protein, the recommended allowance of protein, rather than focusing on one protein, which is just collagen, because your body will use it where it needs to use it. So getting lots of protein in your diet is really valuable, but taking one particular protein, not so valuable. And then also people ask about cosmetic procedures like Botox, getting collagen fillers, things like that. And we didn't recommend it in the paper because there's no evidence that it will do any good. And potentially you could theorize that it might do you harm, but there's been no studies. And ideally, we recommend to all of our patients who have skin fragility to avoid unnecessary procedures where they can. And cosmetic procedures are, you could consider, not a medically essential procedure, so we tend not to recommend them. That being said, I can't monitor everybody, so it's your choice if that's something that you want to do, but we don't recommend them. So future work, as you can tell, there's very little evidence. To be able to produce good, solid, evidence-based guidance, we need lots of information. So we need fundamental science, clinical evidence, trials, and studies. And we're working on them at the moment. So at the moment, my PhD is focusing on clinical evidence and fundamental science. But we're also, as part of the skin working group, we're linking in with plastic surgeons to try and develop studies and trials. So things are slowly happening. But as I'm sure you know, research takes years and years and years. So we're developing things, but we're not there yet. So hopefully in I don't know, a few years' time, I'll come back and give you the same talk and I'll have loads of really helpful, solid things to say. But at the moment, that is what we have. So I'd just like to thank EDS Support UK for putting this webinar on. I hope it's been really helpful, but also my teams at Imperial College London who are supporting my research. And obviously the National Ehlers-Danlos Syndrome Service where I work and who are funding my research and are really, really supportive. So thank you for everyone listening. Thank you to all the people that have helped me get here today. And I would love to talk about your questions, your thoughts, your ideas. And yes, and I've got one last picture of a
Ah,
hug with a biscuit. Okay.
finish with a dog. That's what I like.
Absolutely. Why not?
Gorgeous. Right, as you
Shall
can
I?
imagine, Chloe, that was so interesting. Thank you so much. Lots and lots of information in there as well. So just to kind of remind everybody, you will be able to watch the recording again because I know there was such a lot going on in that. So thank you so much. As you can imagine, tons of questions. So I'll just get
Yeah.
straight into
Shall
it if
I
that's
stop
okay.
sharing?
Yes, please. That would be
Right.
quite useful. I can see you then.
Okay. Hello.
Lovely. Right, okay, let's start. What are your thoughts about red light therapy in wounds and healing or bruising?
So that is a good question. My understanding, so I'll be honest, I'm not totally up to date with red light therapy. My understanding is that the tech is still quite new and how much impact it actually has, people aren't really sure. That was the latest article that I read, that it's you can't be 100% because we don't really understand exactly what it's doing. If it's having, we also don't necessarily understand what the risks of it are and whether it, for example, would increase, is it like a tanning bed because it's light? So
Right.
would it increase your risk of skin cancer in the future or wrinkling? We don't know. That's information that we don't have. So I wouldn't blanket recommend it to anyone, but if you're someone that uses it and you find it helpful, there's also no definite evidence to say that it's harmful. So why not? But I can't say
Yes,
yes or
there's no
no because
evidence for it.
the data's just not there. So
Thank you.
sorry.
If your skin is thin and translucent, uh, is it reasonable to ask for glue and steri strips instead of stitching?
So I would say it more depends on, rather than the look of the skin, it's the quality of the skin and how fragile it is. So if if your skin is really fragile, so often what happens is when someone's got very fragile skin, regardless of the cause, when you put a suture in, it will do something called, I'm sorry for this phrase, but this is just what it's called. It cheese wires through. So it just
Right.
goes, cuts the suture itself, cuts straight through the skin and adds an extra cut. So if you're someone where that happens to you, ideally avoid sutures or make sure that the sutures are done by someone very experienced in suturing.
Right. That's a really
I,
good point as well, yeah.
yeah, and ideally, the best, I think that glue and steri strips is more effective because they take a lot of the tension off the wound. When I say more effective, I don't mean more effective than sutures. I suppose I mean that they're lower impact on your body because sutures is another thing that your body then has to deal with. Um, and they dissolve over time, so that it kind of promotes your body's own healing. But the way you choose is not based on, it's based on your skin fragility and it's based on how much tension the wound is under. So if the wound is a really odd shape, glue and steri strips aren't going to bring it together. If the
Mm.
wound is really pulling apart, glue and steri strips aren't going to bring it together. So you need that extra support, and sutures are the best for extra support, if that makes sense.
Yeah. Um, Dissolvable stitches. Lots of people saying they get these dissolvable stitches and they don't dissolve and have to have them removed. Is that just it happens to some people, or is that something indicative of skin
So
fragility?
that's really interesting. So I don't think it's indicative of skin fragility, but we do hear about it a lot. And why it happens, we don't really understand. But what you could do is just preempt it and say, look, sutures don't dissolve for me. Can I just have the non-dissolvable ones and just make a plan? We also recommend, which I didn't say in the talk, but I meant to, is that we recommend if you're someone with skin fragility, leave your sutures in twice as long as they normally would be.
Okay.
Sorry if anyone's already left. And that's because the scar itself will be more fragile, so it needs that extra time to build up that support so that it can be without the sutures. But you can just preempt and not have the dissolvable ones and just have the non-dissolvable and have them taken out, which because also then you avoid things like having old sutures which have partially dissolved and it's all just gets a bit
Mm.
messy and it's frustrating as well. But I wish I knew why, because it's fascinating why it's
Mm.
not breaking down. But there we go. We're not there yet.
That's useful to know, though. Leave them in twice as long.
Yeah.
Um, this one, if we have more fragile skin and defective collagen, why do we tend to look more youthful?
So that is a good question. And I would say it tends to be people with hypermobile EDS, where people say about looking more
Right.
youthful. And we don't know why hypermobile EDS happens. So I can't
Yeah.
explain to you why um, the skin isn't kind of wrinkling and sagging in the same way as other people. But, there's lots of conditions out there in the world where even though it's an illness, it has a protection. So, for example, sickle cell disease.
Hmm.
Um, when you're a carrier of sickle cell, it gives you protection against malaria.
Okay.
So sometimes conditions can have plus points and difficult points. So if you look great and you've got a type of EDS, brilliant. I
Just
can't
take it.
explain it to you,
Just,
but enjoy it. Yeah.
just take it.
You don't need the Botox and collagen. You've got it already.
Lots of different questions around bruising. What can help to improve it? They're talking about, people talking about vitamin D, B12. Can you put vitamin C in a cream directly onto skin to help with bruising? I mean, what would be your recommendations? And I think when they say help with bruising, a lot of it's around the colouring rather than.
Yes. So, so I would say so. If you're deficient in any kind of nutrients, it's really good to supplement them anyway. So vitamin D, B12, some people get easy bruising because they're anemic. So
Mm,
iron supplements, although that's difficult if you've got digestive problems because iron can cause
yeah.
constipation. So it's worth, you can have IV iron sometimes, but
And
that's
is
a
that
com
better than taking it orally then?
IV iron tends to have less of the constipation effects.
Okay.
But that's a conversation with your GP, and not everyone can have that because you have to go into hospital, make an appointment to have it done. So it takes a lot of time out of your day. Lots of people are
Mm,
busy. But anyway, it's just something to say. Putting topical is, I think it's better to have the vitamin C orally because it means that your body has the stores of vitamin C to use where your body wants to use them. And ideally, what you want to do is to have the vitamin C constantly producing collagen everywhere. And the idea is that that will help to generally reduce bruising. Your
okay.
skin is designed not to let things in the surface because otherwise we'd go around picking up everything that we walk past, which would not be ideal. So putting things topically um, is okay, but it depends how much your body can absorb, if it can absorb anything. So I would say topical vitamin C um, is fine, but if you're not finding that it's making any difference, I wouldn't necessarily be surprised, and I would definitely go for supplements over topical if you can tolerate them.
Okay.
People say about things like arnica. I don't necessarily know that there's any evidence that arnica speeds up bruise healing or speeds anything up. What you might find is that if you have a bruise or you have an injury where you know there's going to be a bruise, and like you said, it hasn't come out yet and it's on its way, ice and compression will hopefully reduce that.
Mm.
Um,
And people talk
but
about a lot about taking arnica before an operation. So I know a friend of mine who's a devotee of arnica, and if she's having an op or anything like that, she will take arnica for 2 weeks before, and she swears that that will help with healing. Is there any
very
evidence to
interesting.
that?
There's no evidence.
No. Oh, I'm so glad I'm going to tell
But
her.
that's just because the work hasn't been done. So
Right.
whether there actually is or not, do you know what? If something makes you feel like you're in control and that it's going to make a difference, then that's brilliant.
Yeah.
There are some things that do make a difference to bruising after surgery. So cod liver oil is a really big one. So if you take cod liver oil or omega-3 to help your joints, that increases bruising and it increases bleeding during surgery.
Okay.
So that is a good one to avoid if you are going to have a procedure. Um, and the other thing, I did see some comments about spontaneous bruising. So I think that's a really difficult one because people with all EDS types can have spontaneous bruising where the bruise just pops up, you don't know where it's from or what's
Mm,
happening. And obviously that's really hard to manage because you
mm,
didn't know it was going to happen. So if you have that, I just think don't beat yourself up thinking, oh, I could have prevented that or this, because the truth is when people have skin fragility, you're not going to get on top of all of all of the features of skin fragility because it's how your body is. These are just suggestions to try to make life a bit more comfortable and a bit easier, but you can't you
no.
can't manage everything all the time, or you could, but you wouldn't be able to do anything else
I was going to
with
say
your
you'd have to stop normal
time.
life, wouldn't
Yeah,
you?
absolutely.
Bubble
Yeah,
wrap.
yeah, absolutely.
Lots some questions around wounds and healing. There's that obviously that old sort of old school of thought about, like my mum, blow it off and leave it in the air and let the air heal it. Should you is Does that depend on whether a wound is wet or dry, and also what kind of wound, and does a wound need air if it's
So that is a really good question, and it depends on the wound.
right.
So in dermatology, there's a saying, uh, if it's wet, let it dry, and if it's dry, make it wet, which
Okay.
is kind of helpful, but maybe not necessarily so. I would say, so if you've got a wound where it is really um, oozy and looks infected, first of all, that probably needs antibiotics.
Yeah.
But you also need a dressing that's going to wick away all of that moisture and pus and things to get it all out. So that's not necessarily one that needs to be open to the air, but it needs a dressing that's going to pull everything away. So there are dressings that will do that. Um, but that's a specific dressing. So I would make sure you get medical advice for that. So that's that. There are some wounds where, so often in my experience, people with hypermobility EDS and hypermobile spectrum disorder will have what I call skin tears or skin rubs, which is
Yeah.
not the world's best description, but that's my description. So it's where you have a rubbing injury. So sometimes people will scratch loads and find that their skin has kind of started to bleed, or they'll have a rub against something and the top layer of skin just comes away. So, and you can see kind of white, shiny underneath. So it hasn't cut, it's not gone all the way through to the dermis, but the top layer has definitely come off. And then you get a clot and it's scabs over. But that is a good one to leave open to the air because it's
Yeah.
not gone through the dermis. So the risk of getting an infection is really low. But if you keep it moist and keep it covered, then it will start it potentially that's a good opportunity for bugs to get in. So that's a good one to just leave and let breathe. A bit like a
Okay.
scab. So when something's a penetrating injury, so when it's gone through that deeper layer of the skin, that's when you want it covered because you don't want bugs to get in there. If that makes sense.
Yeah, it does. Um, the wound management page that you had on there, I did do a quick screenshot and I've shared it in the chat because people, it was so informative and people were
Yeah.
like, "I want that." And presumably, can they use that to print it off and take it to their medical professional to
Yeah.
say, yeah, to advocate for themselves? Lovely.
Yeah, that should be fine. And the paper you can point them to the paper as well. Um, so I don't because of how the journal is, I don't think that you might have to pay for it as an individual, which is not ideal, but your medical professionals should be able to access it through the NHS. So what you could do is if you've got a really good relationship with your GP, they can print it off. Or if you do end up going into A&E with a wound, you can say, this is the paper, you can have a look at this paper, if that makes
Lovely.
sense.
I've popped
So
the link in the chat.
amazing. It is frustrating to not have open access papers for
Um,
everything.
ooh, there's so many. I just want to try and do the most general ones that
Yeah.
everybody's been asking about. Um, so lots around things taking such a long time to heal, and I think you've just explained that with the stitches. Even things from blood draws and yeah, insect bites, those kinds of things. Is it just you have to be accept that they're going to take a lot longer to heal, and that's all there is to it, or yeah,
So it really depends. I mean, so so if you're someone that has a rare genetic type of EDS like classical EDS, we understand why things are taking a long time, and it's because the collagen is more fragile, so it just needs longer for that in the remodeling phase. So that's the months of having a wound. It needs longer for that collagen to be produced and laid down properly. If you're someone who has hypermobile EDS where we don't understand, that's often where we see these huge like bite reactions and things, and we don't
right,
understand why it's happening to people and why people are experiencing that. But what I would say is, um, you know yourself better than anyone. And as a medical professional, I know the facts and the literature and the evidence, but I don't know your body as well as you do because I'll only have a snapshot. So it might be worth, if you don't mind treating yourself like a guinea pig, trying various different things to see what helps. So, for example, you could try rescue antibiotics if you have a bite and you know that you have these big bite reactions. To get support with getting like when I say rescue, what I mean is your GP can prescribe you antibiotics that you can take when you have a bite, so you keep them at home and you have them. But to do that, you need a body of evidence to go to the GP and say, look, every time I have a
right,
bite, this is what happens. So photographs are so valuable because you can just say, look, this was in August of last year, this was in September when I had a big bite. Get a photo, then you can take it and say, this happens every time, and I have these big reactions with a big infection. Well, I could head it off with some antibiotics. Potentially, we could avoid all of that. The question is that I think is really interesting. I've got no evidence for this, but this is just a thought, is that is it definitely an infection or is it a big over inflammation? Because we know people in
mm,
hypermobile EDS have these big flares. And is this a kind of skin flare rather than an infection? And I don't have the answers for that because, again, there's very little research. If that's the case, antibiotics won't be very helpful because if it's inflammation with no bacteria,
mm,
the antibiotics can't help. So then it's worth experimenting with other things. You could try things like ibuprofen, you could try topical ibuprofen, you could see if different dressings work to protect it. to stop things getting in. It depends how often you have them and how much kind of self-experimentation you want to do. But with an understanding of how the skin works and how wound healing works, you can try different things yourself, see how they work. And I think that that's justifiable
Yeah.
because there isn't very good evidence. So bug bites and bug bites reactions can be really dramatic. What I would say is don't put off seeing the doctor if it's getting really bad. Just go and see the doctor and show them, and they might and then they can make a decision as well about what you need at the time, because it could be that it's infected, it could be that it's just inflamed. So I think don't put off seeking medical advice as well.
Yeah. And as you're talking, and I know it's not your area of expertise, but I'm also wondering, we know that a lot of people with any type of EDS, especially heads, have a comorbidity of MCAS. And I
Yeah,
wonder when you're talking about those insect bites, whether there might be something in that
yeah,
as well.
exactly. And it's not necessarily bacteria, or it's not necessarily initially bacteria,
Mm,
and that it's that there's a big immune reaction, or the mast cells are kind of really reacting, because
mm,
part of what bug bites have, the reason they get itchy is because they set off everyone's mast cells. But for most people, it's just a little bit. But if you do have unstable mast cells, it would be a really big amount. But
yeah.
then um, trying different things to see what will help that reduce is so you can get topical antihistamine creams,
Mm,
and you can also um, just for symptomatic relief try things like Dermacool, which is also a menthol based cream, which won't it's not therapeutic, but just feels really nice, and it really helps with that, particularly that mast cell based heat and itching. The menthol really helps, so I always recommend Dermacool. It's really nice.
And I'm going to finish on this last question. If you're going in for any kind of surgery, or even small op or something like that, mole removal, something like that, what are the kind of the top key things you should be saying to your surgeon when you have skin fragility?
So the key things are to talk about your distinct type of EDS or HSD. Sorry, um, if I've not been specifically saying HSD,
No, that's fine.
obviously,
Yeah,
um, talk about your distinct condition. Talk about how it affects you personally, and if you've got photos of historical things, that's really valuable because it really helps back up your evidence to say, this is what happened this time, this is what happened this time. And then if you've got any leaflets or any information about your specific EDS type. So for anyone that gets diagnosed through our service, we have leaflets for each different type. And that also gives you weight because they can, if you've got a photocopy of that, they can hold on to it and they can read through it at their own time. It also shows where you've been diagnosed. If you haven't been diagnosed with us and you've been diagnosed somewhere else, which lots of people will have been because we're only a small service, um, I'm sure the EDS UK team have lots of different leaflets and
we do.
information available, which you can
We
use
do.
as well. So the more information, the better, and the more evidence you have, the better. So producing things in a really organized, clear way to say, I've got this type of skin fragility. What that means is this. So it's a rare condition, and it means that my skin can react very badly, or I'm prone to wound infections, or I take a really long time to heal. And this is the leaflet talking about my type of EDS, and this is the recommendations for how it should be managed. What do you think? And then letting them synthesize that into a plan. But the more information, the more evidence, the better. That's all you can
Lovely.
do, really. That's all that's in your kind of control.
Yeah. And you can email our advice line at ls-danlos.org, and we've got fact sheets that we can send to you that you can print off of a whole variety of things, including anaesthetics and wounds and all sorts of stuff. Um, I just want to say thank you. It's been really informative, and I really appreciate you giving us your time today. Thank you so much. And thank you everybody for joining us. And hopefully we will have you back again soon, as you said, once you've finished your new research, etc. But thank you. Really, really great webinar.